Definitions. Total intravenous anesthesia (TIVA) is a general anesthesia technique that uses a combination of drugs administered exclusively intravenously without the use of drugs by inhalation. Anesthesia with gases. Total intravenous anesthesia (TIVA) is a general anesthesia technique that uses a combination of drugs administered exclusively intravenously without the use of drugs by inhalations.
Hello and good day. This is Dr. Hans Barandes. I'm in the operating room today with Dr. Robert Rutledge, and I'm going to discuss TIVA, total intravenous anesthesia. Currently, TIVA is used on all of Dr. Rutledge's gastric bypass patients, and we have proven this technique over thousands of patients across the United States of America. Total intravenous anesthesia is used using propofol, which is a medication that we call milk of amnesia. It is a white medicine that is mixed with remifentanil. Remifentanil is used as a narcotic-based total intravenous anesthetic. We run the remifentanil and propofol in an infusion pump, and it's based on kilogram per minute. So we use the body weight of the patient, and we run the infusion based on kilograms, micrograms per kilograms per minute. And we use a BIS monitor, which is a monitor that monitors the patient's brain waves and the depth of their anesthetic during the operation and after the operation while we are waking the patient up. In anesthesia terms, that is called emergence. The entire patient anesthetic is maintained and balanced using total intravenous anesthesia. The benefits of total intravenous anesthesia are that of decreased problems with respiratory compromise in the PACU area, which is the post-anesthesia care unit, decreased risk and complications of nausea and vomiting, because anesthetic gases are triggering agents for nausea and vomiting, and they are well known to do so. So we have many different reasons for utilizing total intravenous anesthesia. In the bariatric patient population, patients wake up very smoothly, and our operations usually last anywhere from 18 minutes to 40 minutes, and so this is the perfect manageable anesthetic for this type of operation and this duration of surgery.
The inhaled anesthetics consist in torn of gases and volatile liquids. The latter are molecules of halogenated hydrocarbons, among which are allothane, fluorane, isoflurane, sevoflurane, and desflurane. An inhaled anesthetic consists in torn of gases and volatile liquids.
When you step into the OR and look at the anesthesia machines, you will notice that there are 3 color-coded tanks. These contain the volatile gases. Volatile gases are the mainstay of what anesthesiologists use to keep people asleep. There are 3 main volatile gases used: desflurane, sevoflurane, and isoflurane. Nitrous oxide is another volatile gas you may have heard of, but this is typically used for induction in kids or to aid the other 3 gases during wake-up. Before we get into the volatile anesthetics, it is first important to discuss the definition of MAC. You might hear the word MAC thrown about the ORs, or even better, will likely be asked about it. MAC itself stands for minimum alveolar concentration, and is defined as the amount of inhaled anesthetic given for which no movement is observed in response to surgical stimulus in half of subjects. The reason why this is so useful is because it's the only way we can approximate whether a patient will respond to surgical stimulus. Likewise, you might also hear the term MAC awake. This is the minimum alveolar concentration at which anesthetized patients respond to a verbal command, such as squeeze my hand or open your eyes. Now, the reason for having such a term is it allows an anesthesiologist to determine the amount of anesthetic that needs to be administered to a patient that will prevent awareness. This becomes important.
Volatile halogenated liquids. They are organic aerified compounds of synthetic origin that have the capacity to produce 100% anesthesia producing in the patient in a state of analgesia until peri-intravenous. These drugs are often combined with nitrous oxide to improve and complement their action. Volatile anesthetic agents inhalated have cardioprotective effects, which could improve clinical outcomes in patients undergoing coronary artery bypass graft. Cardiac surgery is the surgical specialty that deals with the heart or large vessels, performed by cardiac surgeon. It is frequently used to treat complications of ischemic heart disease, for example, by means of a coronary bypass, to correct congenital heart malformations, or to treat valvular disease of the heart due to various causes, such as endocarditis. It also includes heart transplantation.
There are numerous things that result in a patient needing to have heart surgery today, and that would include a problem with their coronary arteries, blockages of their coronary arteries. Then you have a huge category that's actually growing now where the valves either leak or they're too tight. The third category, although less common but still exists, in which patients have had congenital heart problems that they were born with, and now they've grown into adulthood, either having had them diagnosed late in adulthood or knowing that it was there but now needing to have something done about it. A fourth category would be electrical problems with the heart, in which there would be some conductivity problem or rapid heartbeat problem that would result in needing to have specialized studies done and then possible interventions. Traditionally, everybody knows about open heart surgery through what we call a sternotomy, where people, quote, have their chest cracked, which is the typical terminology for that, but basically it's dividing the breastbone, going through the middle of the sternum, to get access to the heart. And this has served physicians and patients very well for 30, 40 years. We have become more and more comfortable with doing the same types of procedures through smaller incisions. So we have begun a fairly comprehensive program where every patient that comes to our center is looked at initially for a minimally invasive approach, a small incision approach or a robotic approach, one of the two. And if they are candidates for that, then that's how we do them. If we can't do it that way, then of course we offer them and provide them the
Applications in medicine. In surgeries, in cardiac, neurological, and abdominal. Advantage and disadvantage. Advantage: the reduction in the incidence of post-operative nausea and vomiting, less air pollution, more predictable and rapid recovery, greater hemodynamic stability, preservation of hypoxic pulmonary vasoconstriction, reduction of intracerebral pressure, and lower risk of organic toxicity, rapid recovery of consciousness and psychomotor function, greater speed of recovery, antiemetic effect, and a lower incidence of postoperative nausea and vomiting.
Hi, I'm Dr. Raghunath. I've done my MD in anesthesiology. Right now I'm practicing as a senior consultant in the Department of Anesthesiology, Fement Hospital. Now, general anesthesia can be administered either through mask or through laryngeal mask airway or through endotracheal tube. Now, laryngeal mask airway has got a lot of advantages when you compare it with an endotracheal tube. This is laryngeal mask airway, which was invented way back in 1988. It has been in practice since 1998 by Dr. Archie Brain. Now, this laryngeal mask airway has got a small mask surrounded by a cuff with a tube attached to it. This laryngeal mask airway is usually, when you put it into the patient, is usually present at the on top of the windpipe, and the other end is used to deliver oxygen and anesthetic gases. When you compare it to endotracheal tube, it's very easy to use it. Number one. Number two, when you compare it to the endotracheal tube, the hemodynamic changes of the patient is very, very minimal while using an laryngeal mask airway, either during induction or at the time of emergence of the patient from the anesthesia. The other advantages of this laryngeal mask airway is that the chances of laryngospasm, bronchospasm or sore throat is very, very less, and the requirement of anesthesia during the procedure is also very, very minimal, less when you compare it to an endotracheal tube. And the oxygen saturation at the time of emergence is also very good when you compare it to an endotracheal tube.
Disadvantage: several toxic effects on organs by their metabolism, increased incidence of malignant hyperthermia, and second, the safety margin of these drugs is small. The pharmacological effects have a short duration. Other advantage: second, the only ones we can monitor in spirit exhaled gas equals the amount of drug received. Lower dose of relaxant and opiates for the same effect. Statistic in Ecuador. In Ecuador, the use of volatile anesthetic inhaled often does not result in the best way because it produces some accidents such as poisoning. For that reason, there is not much preference for the use this type of drugs, and with respect to total intravenous anesthetic, they are much better absorbed, last much longer, and do not produce poisoning. In 72%, doctors prefer the use of total intravenous anesthetics in Ecuador. In conclusion, in recent years, the use of inhaled versus intravenous anesthetic in cardiac surgery has led to the development of various investigations, although it is more frequently used technique. Inhaled anesthetic have also been safe, treatable, prove adequate intraoperative monitoring, and cardiac hemodynamic stability. In patients with the intrathoracic pressure, inhaled agents are a good alternative to anesthesia with TIVA, especially in places with limited hospital resources.
If you've had surgery, you might remember starting to count backwards from 10, 9, 8, and then waking up with the surgery already over before you even got to 5. And it might seem like you were asleep, but you weren't. You were under anesthesia, which is much more complicated. You were unconscious, but you also couldn't move, form memories, or hopefully feel pain. Without being able to block all those processes at once, many surgeries would be way too traumatic to perform. Ancient medical texts from Egypt, Asia, and the Middle East all describe early anesthetics containing things like opium poppy, mandrake fruit, and alcohol. Today, anesthesiologists often combine regional, inhalational, and intravenous agents to get the right balance for a surgery. Regional anesthesia blocks pain signals from a specific part of the body from getting to the brain. Pain and other messages travel through the nervous system as electrical impulses. Regional anesthetics work by setting up an electrical barricade. They bind to the proteins in neurons' cell membranes that let charged particles in and out and lock out positively charged particles. One compound that does this is cocaine, whose pain-killing effects were discovered by accident when an ophthalmology intern got some on his tongue. It's still occasionally used as an anesthetic, but many of the more common regional anesthetics have a similar chemical structure and work the same way. But for major surgeries where you need to be unconscious, you'll want something that acts on the entire nervous system, including the brain. That's what inhalational anesthetics do. In Western medicine, diethyl ether was the first common one. It was best known as a recreational drug until doctors started to realize that people sometimes didn't notice injuries they received under the influence. In the 1840s, they started sedating patients with ether during dental extractions and surgeries. Nitrous oxide became popular in the decades that followed and is still used today, although ether derivatives like sevoflurane are more common. Inhalational anesthesia.
The use of total intravenous anesthesia activa in emergency thoracic surgery was beneficial and facilitated the prevention of complications in the trans and post-operative period. Likewise, the effectiveness of this technique in terms of stability and recovery of the patient to one it is applied during the surgical act in proven from the demonstration made. Thanks.